Hello, today I'm going to discuss aortic regurgitation as a mechanical problem that quietly injures myocardium long before symptoms announce themselves. We're going to discuss this uh, based on recommendations from the ACC-AHA Valvular Heart Disease Framework, starting from an at-risk through symptomatic severe disease and the expectations that severe disease and complex decisions flow through a multidisciplinary heart valve team. In aortic regurgitation, blood flows backward from the aorta into the left ventricle during diastole. That retrograde flow carries a hybrid load. Ventricle must handle extra diastolic volume while generating enough systolic pressure to maintain forward output. The trap is that compensation can look reassuring for years, especially if you focus only on a normal ejection fraction. The goal of contemporary guideline-based care is to intervene at the point where compensation is failing, not after irreversible remodeling has occurred. As you go slide by slide, keep one question in mind. Where is the ventricular compensation decompensation continuum, and what data best defines the inflection point? Now, let's start with the mechanism, because mechanism drives both prognosis and feasibility of repair. Is the aortic regurgitation primary or organic, as in the situation where it's a leaflet problem? The valve itself is intrinsically abnormal or damaged. Classic culprits include a bicuspid aortic valve, rheumatic changes, infective endocarditis with leaflet destruction or perforation. Secondary aortic regurgitation or functional AR is not primarily a leaflet problem, but rather it has to do with dilated aortic root. The dilated aortic root dilates the annulus and aortic regurgitation occurs. Think such as Marfan syndrome or connective tissue disorders, long-standing hypertension, all of which cause aneurysm. Clinically, getting the primary versus secondary call right matters because it determines whether optimal operation is valve repair, valve replacement with root surgery, or root surgery alone. Now, bicuspid aortic valve deserves a separate consideration. First, if there's a valvulopathy or abnormal number of cusps, and the abnormal geometry promote eccentric jets and turbulent flow, so you get intrinsic regurgitation. Second, there is an accompanying aortopathy, the disease of the media of the root of the aorta, which produces a dilatation of the ascending aorta, even in the valve and hemodynamics are not dramatic. This matters because the valve and aorta frequently need to be addressed together. So for bicuspid valve disease, watch the valve is not enough. Longitudinal imaging has to track aortic dimensions, growth rate, relationship between the valve dysfunction and aortic remodeling, because aorta can become the primary surgical target. Now, in rheumatic heart disease, aortic regurgitation is heavily shaped by epidemiology and access to care globally. Mechanism is immune-mediated injury after rheumatic fever, followed by progressive neovascularization and fibrosis. Over time, leaflet edges thicken, retract, and lose pliability, creating a fixed regurgitant orifice. At the bedside, rheumatic valve disease should prompt you to look for multivalve involvement, atrial fibrillation, and to align anticoagulation choices with the presence of rheumatic mitral stenosis, where vitamin K antagonists dominate and there is no role for the DOACs. Now, you should remember acute versus chronic aortic regurgitation. In acute regurgitation, the LV compliance, there's zero time for adaptation, so LV EDP rises, and the clinical manifestation is premature closure of the mitral valve and cardiogenic shock. In chronic aortic regurgitation, there's eccentric hypertrophy, and there's enough time for the compliance to work with a flattened compliance curve. Therefore, there's preserved forward flow, and the patient is initially asymptomatic. Remember, always remember where is the left ventricle in this continuum. Now, during diastole, left ventricle reserves two inflows in aortic regurgitation: the normal mitral inflow plus the regurgitant aortic volume, that is pure volume overload. But to maintain forward cardiac output, ventricle must eject a larger stroke volume into the aorta during systole. This often occurs against systemic vascular resistance, creating a systolic pressure burden layered on top of the volume load. The net result is high energy demand state. Ventricle is doing extra work for every beat, even when the patient feels fine. This is why chronic severe AR is not benign simply because the patient is asymptomatic. Should always remember the Laplace's law. The classic compensated response to chronic AR is eccentric hypertrophy. Step 1 is geometric left ventricular dilatation to accommodate the larger diastolic volume, and therefore the radius increases. Step 2 is cellular. New sarcomeres are added to in series to increase chamber radius and wall mass. Then this is where the Laplace's relationship becomes intuitive. LV hypertrophy tries to normalize the wall stress. However, compensation buys time, but the longer the ventricle must sustain this remodeling program, the greater there is the risk of fibrosis and myocyte loss, and when the compensatory mechanism breaks. This leads to maladaptive transition and cellular exhaustion. Step 1 is a mechanical stretching, asymptomatic compensation. Step 2 is neurohumoral cascade activation with RAAS and sympathetic nervous system kicking in. This leads to interstitial fibrosis and apoptosis with angiotensin II promoting pathological stiffening. Then there is depressed LV ejection fraction, a rigid LV, and diastolic pressure transfers back to the pulmonary bed, causing dyspnea. Now, the increased systolic forward flow raises the systolic pressure. The rapid backflow into the left ventricle with leads to a lower diastolic flow with a wide pulse pressure. This leads to numerous clinical signs called by various names: the Corrigan's or water hammer pulse, the head bobbing sign, etc. Now, you should also remember that the aortic regurgitant jet often strikes the back of the mitral valve, pushing it forward, causing a diastolic rumble of mid-diastolic murmur of mitral stenosis, even though there isn't mitral stenosis. So, this decrescendo murmurs suggests severe mitral regurgitation. Thus, on physical examination, if Austin Flint murmur is auscultated, you should consider that the patient has severe aortic regurgitation and not mild or moderate. Now, on echocardiography, there are several features to consider: vena contracta, regurgitant fraction, pressure half time. The vena contracta is the narrowest portion of the regurgitant jet, just downstream from the regurgitant orifice. Because it reflects the effective regurgitant orifice area, it behaves as a direct surrogate for lesion severity. Key threshold is simple. A vena contracta width greater than 6 millimeters is strongly supportive of severe aortic regurgitation, especially when there's concordant other parameters such as width relative to LVOT or holodiastolic flow reversal in the descending aorta. Pressure half-time measures how quickly the pressure gradient between the aorta and left ventricle equalizes, especially during diastole. With more severe regurgitation, the pressure equalizes faster and the Doppler deceleration slope becomes steeper, the half-time shortens. A pressure half-time below 200 milliseconds is classically consistent with severe aortic regurgitation. Pressure half-time is not a pure valve metric. It is also controlled by ventricular compliance and aortic stiffness. So in chronic well-compensated AR, pressure half-time can only look moderate, and in diastolic dysfunction, it can look falsely severe. Use it as supporting evidence, not a single deciding vote. A pressure half-time of less than 200 milliseconds is a severe aortic regurgitation marker in the right clinical setting. Now the 50 rule. A diastolic ejection a ejection fraction drops below 50% or end diastolic dimension exceeds 50 millimeters, then surgical intervention is considered necessary. Ejection fraction can remain deceptively normal because the ventricle ejects a large total stroke volume into a low impedance aorta even as intrinsic myocardial performance is declining. Global longitudinal stress measures myocardial deformation and can detect subclinical systolic dysfunction earlier than ejection fraction. Conceptually, GLS falls first and then the ejection fraction. Current guidelines still anchor decisions on symptoms, LV size and function by standard measures such as ejection fraction. However, remember that LV volumes, CMR-based fibrosis, global longitudinal strains are tools for earlier risk stratification. Chronic aortic regurgitation has a long compensated phase, years to decades, characterized by eccentric hypertrophy, preserved EF, and a few symptoms. But once maladaptive remodeling dominates, decompensation accelerates over months, interstitial fibrosis, myocyte apoptosis, falling LV compliance, drive rapidly rising filling pressures, symptoms emerge, and systolic dysfunction may become less reversible. Thus, the physiological justification for lower thresholds and earlier referral are important to remember. The clinical objective is not simply to treat symptoms, it is to prevent crossing into the state where myocardial injury and dysfunction persist even after the valve is corrected. Now, medical management. Medical therapy has a role in aortic regurgitation, but we need to be clear about what it can and cannot do. Reducing afterload can improve forward flow and reduce regurgitant fraction in the short term. For patients with hypertension, blood pressure control is essential, often with ACE or ARB or dihydropyridine calcium blockers. However, in asymptomatic severe AR with preserved ejection fraction, trials have not shown routine vasodilator therapy to change the natural history enough to replace timely surgery. Beta blockers require nuance. By slowing the heart rate, they prolong diastole. This is the interval when regurgitation occurs and can increase regurgitant volume. They may still be appropriate for specific indications like aortopathy management or arrhythmia control, but they are not the AR therapy in the way surgery is. Symptom onset often remains the strongest clinical signal that compensation has failed and severe AR has become clinically consequential. For asymptomatic patients, guideline thresholds focus on LVEF at or below 55%, LV end systolic diameter above 50 millimeters or index above 25 millimeters per square meter. This signals that dilatation has crossed a safer boundary. These thresholds are designed to prevent irreversible LV damage. Key is serial measurement and trend recognition. The ventricular trajectory matters as much as a single data point, as opposed to aortic stenosis, where there's heavy calcium and TAVR is an option. In aortic regurgitation, there is a problem with the aortic root, and TAVR is not a solution. Therefore, as we are considering surgery, we really have to focus on a clean, clear indication. Let's close with some practical checklists. First, aortic regurgitation is not just volume overload, it is dual volume and pressure overload that forces eccentric remodeling and sustained energetic cost. Second, track structure, not just ejection fraction. Follow LV and systolic dimension and volumes. Consider strain or CMR when the story is discordant. Also remember the aortic root, which may become a surgical indication in and of itself. Third, the most important, intervene before irreversible fibrosis and mechanical decompensation occur when symptoms emerge or LV thresholds are crossed. This indicates that the window for full recovery is narrowing. Finally, don't make valve decisions in isolation. Same guidelines that lowered AR intervention thresholds also emphasize shared decision making and multidisciplinary evaluation because valve durability, comorbidity, and patient goals matter as much as the anatomy. If you remember one sentence in aortic regurgitation, the ventricle tells you when to operate. You should listen with the right measurements. Thank you for listening. More to follow.